Hello everyone. Good evening. Good evening everyone. Good evening everyone. So today we are live and we'll be talking about neonatal screening. So we'll just wait for a minute for other students to join in, and also I'll also log in the eMedicos app. So here we are. So today we are live. So what is neonatal screening, everyone? So basically, by neonatal screening, what we mean is that we are trying to diagnose disorders at birth in a child who is not having any symptoms. So basically, this child has the disease and we are trying to diagnose it early at birth. Okay, so neonatal screening is basically diagnosing disorders in pre-symptomatic patients at birth. Okay, so before we go further, all of you, can you see this on your screen? Can you see this heel prick on your screen? Can you see this drop of blood? So all of you, today we will be talking about just dried blood spot. So we will be talking about dried blood spot, and we will also be talking about what else can we do. Okay, just give me 1 minute to move the screen. Just give me 1 second. I'll just use my mouse. Hi everyone, just give me 1 second to check my screen here. It seems to jam. 1 second. So all of you, can you see me? Yeah. Hi. So my first question to all of you is, newborn screening is which type of prevention? So all of you have been reading PSM since so many months now, even years now. So can anyone tell me, newborn screening is which type of prevention? Is it primary? Is it secondary? Or is it tertiary? So anyone in the class? Newborn screening is which type of prevention? Primary? Primary, we are trying to diagnose this disorder before it happens. That's primary. Secondary or tertiary? And actually, all of you are wrong. Newborn screening is actually a secondary type of prevention. What do I mean by secondary prevention? So, all of you, secondary prevention is basically, first let's talk about primary prevention. So, primary prevention is that before it happens, you are trying to diagnose that disorder. Okay, so primary prevention means looking at this disorder in carriers. Okay, so you are looking at this disorder in carriers. So you are doing a genetic counseling in carriers. Now, newborn screening is a secondary prevention. It means that we are trying to diagnose this disorder in a pre-symptomatic child. ओके सो होने से पहले बच्चे को डिजीज है ओके इन सेकेंडरी प्रिवेंशन this child already has a disease but we are trying to diagnose it early. And what is tertiary prevention? By tertiary prevention I mean is patient has a disease but we are trying to prevent the burden of the disease, so we are treating the disease so that you prevent the disability. So today I'm talking about all of this in terms of genetics. So in terms of genetics, primary prevention means doing a counseling and doing a screening in carriers, in the parents. Secondary prevention is basically trying to diagnose this disorder in a child. So newborn screening guys, is actually a secondary prevention in a newborn. We are trying to diagnose this disorder in a pre-symptomatic newborn before he gets the symptoms. Okay, so in terms of genetics, so I thought I'll also discuss that it is secondary prevention. So let's go take you further. And my question to you is, all of you have learnt about screening. Okay, all of you have learnt about screening. You learnt about, pap smear. You learnt about so many disorders by which we do screening. So how do you do screening? You can only do screening in a disease which is relatively common and it is very serious. So it is a serious disorder, and if you can diagnose it early, you can prevent the morbidity. You can even, if you can treat it early, you can prevent the morbidity. So we can do screening for a disease in which screening method is cheap and easy. Okay, so screening method is cheap and easy. Okay, so for example, pap smear. Pap smear is simple. So similarly for genetics, also you should be able to diagnose it early by a easy, cheap test. For example, today I'll be talking about dried blood spot. Okay. Next is early treatment is effective and inexpensive. So for example, today if we talk about hypothyroidism, early treatment with thyroxine is very simple, it is inexpensive, and it is very effective. Okay, all of you, are you able to see me? Okay, so just 1 second, uh, I'll ask them to log in again. Give me 1 second. Just give me 1 second. So all of you, tell me when you can see the screen, and then we'll begin. Actually, my camera got hanged. I had to disconnect the camera, so that's why. So just type in yes when you're able to see me. Okay, yes, it is. Great. Okay, so we have already discussed about primary, secondary, and tertiary. Now, my question to all of you guys is that which disease can we diagnose by screening? So I said it should be a disease which is common and serious. So you need to know about a disease which is common and serious. For example, say cervical cancer. For example, hypothyroidism. Okay. Then screening method, whether it's for pap smear for cervical cancer or say dried blood spot we are talking about today for TSH, it should be easy. You need to have an early treatment. So for example, if you are able to diagnose hypothyroidism early, you have an effective treatment for hypothyroidism, thyroxine. It is very cheap, just few paisa drug, and it is an effective treatment. And all of you, we use a screening method for a disease in which the benefit of treating is much more than the cost of a small test. So benefit of treating hypothyroidism is almost 10 times the cost of a TSH. Okay, so I have a question for all of you, and I'm sure you can see this on your screen. My question to all of you is, here is a child. This child has a developmental delay, global in all fields. He has developmental delay, he has hypotonia, you can see umbilical hernia, mental retardation. So all of you, can you tell me what is your diagnosis in a child who comes to you like this? He is around 1 year old and he has developmental delay, hypotonia, umbilical hernia. What do you think, guys? In the newborn period, he also had prolonged jaundice. So in the newborn period, he also had prolonged neonatal jaundice. So can anyone tell me what is your diagnosis? All of you, I want all of you to type and tell me what is your diagnosis in this child. So all of you, I'm waiting for your responses. I'll just put my cell phone right in front. Of course it is hypothyroidism. But guys, congratulations to all of you. But the problem is we diagnosed hypothyroidism when it was too late. This child is already mentally retarded. You can't do anything about this. So guys, congratulations to all of you. But for this child, it is too late. So in fact, remember that there is an inverse relation between the age at diagnosis and IQ. So if you diagnose hypothyroidism in a newborn, you have, okay, so in a newborn, you have a very good IQ outcome. But in a child like this, so as you can see on the screen, if you diagnose hypothyroidism after 6 months, he will be mentally retarded. There's no doubt about this. Okay, so I'm just trying to imply we need to diagnose these disorders early. Okay, so late you diagnose, the IQ will already be gone. Okay, so of course, congenital hypothyroidism is the most common preventable cause of mental retardation. So remember all of you, congenital hypothyroidism is the most common preventable mental retardation. So how can we diagnose it early? Anyone? How can we diagnose congenital hypothyroidism early? By doing a TSH. So yeah, you are right, by doing a TSH and maybe T4. We'll talk about this. So all of you, we live in India. So first we'll talk about India, then I'll tell you about the whole world, what they do. So in India, in fact, congenital hypothyroidism is the most common disorder, which is a preventable disorder, which you can diagnose by a very simple screen. So remember, the prevalence of congenital hypothyroidism in our country is 1 in 1000. So in fact, we should try to diagnose congenital hypothyroidism early because it's in fact the most common preventable disorder in our country. Okay, phenylketonuria is 1 in 10,000. So all of you, this is the data from our country. Okay, for those who are from foundation batch, you will be asked, a short note on, neonatal screening. So all of you, this is common sense. So these are common disorders in our country. Phenylketonuria is 1 in a 10,000. Okay, so phenylketonuria is not very rare. It is 1 in a 10,000 in our country. CAH, we'll talk about this today. Congenital adrenal hyperplasia is 1 in 15,000. Okay, galactosemia is 1 in 60,000. So this is comparatively rare, but in our country we should be, if we have money, we should be looking at congenital hypothyroidism, phenylketonuria and CAH. Okay, so first let's talk about hypothyroidism, and I'll be taking you to the physiology of the thyroid hormone. So all of you, this orange and this yellow below is the thyroxine hormone. So all of you remember three important points, 3 points. Number one, thyroxine is important for the brain development in all stages of the brain. All of you, on the top are the stages of the brain development, and thyroxine is needed for brain development in all the stages of brain development. Okay, whether it's neuronal migration or whether it's the formation of synapses, thyroxine is very important. Number two, in the first trimester, this is the first trimester, in the first trimester a child gets thyroxine only from the mother. Okay, so in the first trimester a child's brain development is dependent on the thyroxine from the mother. So all of you, if mother is hypothyroid, then yes, even a baby can have hypothyroidism. Okay, because he is not able to get thyroxine from the mother in the first trimester. Now first trimester onwards, and can you see this yellow point, these yellow dots, this is thyroxine from the child. So first trimester onwards, now there's a contribution of thyroxine from the child also, in addition to the maternal thyroxine. So remember that as the child grows, thyroxine from himself, okay, thyroxine from himself is also responsible for his brain development. Okay, all of you. So brain development is important first trimester onwards, and you need to have a contribution from the child. Now, as soon as a child is born, all of you, as soon as a child is born, what happens to the TSH? Guys, as soon as a child is born, he is exposed to a cold world. You know, दुनिया कितनी ठंडी है, you know, cold environment, cold people. Okay, he was comfortable in utero, and suddenly, you know, he's exposed to cold people, you know, cold environment. He doesn't like to be born, guys. Bacha feels I was cool in utero, I mean warm in utero, and he's exposed to a zalim dunya, stress. He's exposed to stress and the cold environment, cold people. So the TSH rises, all of you, in the first 48 hours because of the cold stress. Okay, so, and can you see, all of you, the rise in the TSH? See here on the left, the rise in the TSH occurs within the first 30 minutes. It occurs within the first 30 minutes. So इसका मतलब क्या है कि you can do a cord blood for TSH. You can do a cord blood. You can do a cord blood for TSH, but after half an hour you cannot do a TSH because it will be falsely high. So all of you, please remember that you can. I'll explain it to you later also. You can do a TSH in cord blood. अगर सिर्फ TSH करना है, if you have to just do TSH, you can do cord blood. Now you can see the TSH peaks in the first 24 hours and then it falls in the next 5 days. T4 follows TSH, so the peak of T4 is after TSH. So I'll just tell you 2 points. Number 1, मैंने कहा cord blood can be done for TSH, and number 2, if you have not done a cord blood, then in the first 48 hours TSH will be falsely high. Okay, so you will have more of false positives in the first 48 hours. Okay, so what is the best time to do TSH? So if I ask you what is the best time to do TSH, either you do a cord blood or you do after 48 hours to 6 days. This is according to the American Academy of Pediatrics. The American Academy of Pediatrics says after 48 hours to 6 days. And even your OP Ghai textbook says 3 to 5 days. This is OPG, the OP Ghai textbook. Okay, so either you do cord blood or after 48 hours. Now, but remember, all of you, today it's not just about TSH, guys. There are many other disorders which we can diagnose by early screening, and all other disorders are usually diagnosed after 48 hours. So for example, for PKU, for phenylketonuria, the disorder is diagnosed on a fed state. Okay, कब करते हैं metabolic disorder, कब diagnose करते हैं? On a fed child who is feeding well. So amino acids, lipids, they accumulate in a fed child. So remember, most of us diagnose all of the disorders after 48 hours. Okay, because you know we have to do many other disorders, so we diagnose all of them after 48 hours. So even TSH all over the world will be mostly done after 48 hours, along with other tests like TMS, and I'll come to those tests in a while. Okay, so what are the strategies? So guys, my question to you is, what should be the strategy? TSH only? Okay, what should be the strategy? TSH only or T4 first or both? So I'll ask all of you, what do you think should be the best strategy? If you have money, would you go for just a TSH? Just a TSH? or TSH followed by T4, T4 followed by TSH, or both? What should be the best strategy, guys? And I'll wait for your answer. You can type. I'm waiting for your response. What should be the best strategy? Every strategy has some issues. If you do a TSH first, and if it is high, you do T4. Now there are some conditions, all of you. Now there are some conditions in which TSH can be normal. So what are the issues with the first strategy? There are some conditions in which TSH is normal. किसमें? Central hypothyroidism. It is not a problem of thyroid. It is a problem from the pituitary. Central hypothyroidism में your TSH can be normal. There may be some children who have a delayed rise of TSH. This TSH rises late. So in children who have delayed rise of TSH, your TSH may be initially normal, later on it increases. And lastly, there's a condition called thyroid binding globulin deficiency. In thyroid binding globulin deficiency, also your TSH may be normal. Now what if I do, in America, initially they used to do T4 first. Now if you do T4 first, now very nicely answered by one student, there is an issue in this strategy also. In subclinical hypothyroidism, it is called subclinical compensated hypothyroidism. So in subclinical compensated hypothyroidism, initially T4 may be normal. If you are compensated, T4 सबसे important all of you. So if you are compensated, T4 may be normal. So ideally, if you live in an ideal world, where you get Pfizer and Moderna vaccines, and if you live in an ideal world, ideally you should do both. Okay. But remember, if you see a TSH is high, this is done on a filter paper. So you should confirm it by a venous sample. So you should confirm it by a blood sample. You should confirm it with a venous blood sample. Okay. So what is a high TSH? So all of you, what is a high TSH? So high TSH is a TSH more than 20 in the first 2 weeks of life. So remember, according to Indian Society of Pediatric Endocrine, a TSH more than 20 in the first 2 weeks and more than 10 beyond the 2 weeks is high. Okay, so remember, TSH more than 20 in the first 2 weeks and more than 10 after the first 2 weeks of life is high. And I would like to tell you one thing, if TSH is more than 80, straight away start treatment. Don't wait for anything. Okay, so according to the Indian Society of Pediatric Endocrine and the AIIMS NICU protocols. So today whatever I am telling you is from the AIIMS NICU and the Indian Society of Pediatric Endocrine. If TSH is more than 80, don't wait for anything, straight away treat those patients. We don't want to waste time here. Okay, so more than 20 is high, more than 80 is very, very high. So how do you collect the sample? So remember all of you, the first sample today we talked about is cord blood. Now remember, cord blood is collected from the maternal side. इसका क्या मतलब है maternal side? इसका मतलब है कि baby is gone, we clamped his cord, baby is gone, okay, in his cot, okay. So this rhymes, we clamped his cord and he's gone to his cot. And we take the cord blood sample from the maternal placental side. Okay, वहां से लेते हैं. Now in a baby, we do a heel prick. So on your screen is a heel, and basically these arrows depict that we take the sample from the peripheries of the heel, not from the center. So we try to take it from the peripheries of the heel, not from the center. This is because of two reasons. If you take it from the center, you may hit the plantar arteries. So all of you know anatomy more than me. So you will see that plantar arteries may be pricked if you try to prick, slightly medially. And secondly, repeated pricks in the center can cause calcaneal osteomyelitis. So repeated pricks in the center can cause calcaneal osteomyelitis. So on your screen is a normal card, all of your hospitals. Okay. Yes, Dr. Prerna, we need to do TSH and T4 ideally in all. Okay, this is what I'm trying to emphasize. Every baby in the world should get a TSH. Okay, and if possible, TSH followed by T4 or both simultaneously. So we prick and we just need 2 drops of blood, 2 बूंद. आज हम 2 बूंद पोलियो की नहीं बात करें, 2 बूंद जिंदगी की. Mr. Amitabh Bachchan talks about 2 बूंद जिंदगी की. Now this is also 2 बूंद of blood on a filter paper. Okay, and we need to have a full circle of blood in the whole in this circle. It should completely, you have a whole blood here. Okay, you should not have spots here or layering here. We need a good drop of blood on a filter paper. We dry the filter paper and transport it to the lab on room temperature. Okay, so all of you, I'll ask you a question. On your screen is a child. So we'll be talking about the clinical features here. So on your screen is a child who has delayed development. Okay, who has a very shrill cry, a protruded mouth, dry skin. Can you see his dry skin on the right side? Can you see his dry skin, dry leathery skin, umbilical hernia? So of course these are features. Okay, so of course these are features of congenital hypothyroidism. There are no points for guessing this. Dry skin, delayed development, and umbilical hernia is congenital hypothyroidism. Now the first test, but before that I would again say X-ray important nahi hai. If you got a TSH which is very high, more than 80, straight away start treatment. Okay, so there is no need for this X-ray. But still, if you do a X-ray of the knee joint, all of you know from your forensic medicine that this lower epiphysis of femur comes at birth. Now this will be absent. So in congenital hypothyroidism, the lower femoral epiphysis will be absent. Okay, lower femoral epiphysis will be absent in congenital hypothyroidism. Now, what is the most common cause of congenital hypothyroidism? All of you, what is the most common cause of congenital hypothyroidism? Hota kyun hai? Anyone in the class? I want all of you to type. What is the most common cause of congenital hypothyroidism? Is it maternal or the problem in the child's thyroid gland or some problem in the hormogenesis of the thyroid gland? So remember, I'll wait for one more response. Remember that the most common cause of congenital hypothyroidism is dysgenesis. So half of the students are wrong. It is dysgenesis of the thyroid gland. So remember, 85% of the congenital hypothyroidism is dysgenesis of the thyroid gland, dysgenesis. So on your screen on the right side is actually a technetium scan. It is a technetium scan and you cannot see anything black in the neck area. There is nothing black in the neck area. So because there is no, so remember, it is not maternal. No, whoever said maternal is wrong. Okay, so it is actually dysgenesis of the thyroid gland. Okay, and we diagnose this by a technetium scan. So a technetium scan tells us about whether this gland is here or ectopic. Okay, thank you everyone for answering this question. And my question to you is, how did now I'll take you to other disorders in which we can also have some other disorders by which we can diagnose this. So can anyone tell me, how did neonatal screening start? On your screen is the father of neonatal screening. So can anyone tell me who is this on your screen? This photograph is of which scientist? And I'm happy to see a lot of interaction today. So can anyone tell me, this photograph is of father of neonatal screening? Who is this? Who is this man way back in 1960s? At least type something. If you don't know, at least say, I don't know, sir. You're right. He is Dr. Guthrie, Robert Guthrie. And you know the Guthrie's test? So Dr. Robert Guthrie was a scientist, and actually his child was mentally retarded. His child was mentally retarded. So because of his son who had mental retardation, he discovered the Guthrie's test for phenylketonuria, which is a bacterial inhibition test. Way back in 1960s, he discovered the first neonatal screening test, the Guthrie's test, the bacterial inhibition test for phenylketonuria, which was based on the principle that this Bacillus subtilis needs phenylalanine to grow. Bacillus subtilis needs phenylalanine to grow. So in children who have, uh, phenylketonuria, so they basically look at the culture, okay, and then they look at the inhibition. So remember, this was a bacterial test, a microbiological test. So, but nowadays, all of you, we don't do Guthrie's test for all the metabolic disorders. For all the metabolic disorders, whether it is amino acid, lipid, or other enzyme, we do TMS. For the NEET PG aspirants, TMS is the word. This question comes in every NEET PG, came in 2018, 2019. Which test is done to diagnose metabolic disorders? Tandem mass spectrometry. Okay, so we do it after 48 hours by a heel prick on a filter paper. It's called TMS. Okay, for the metabolic disorders. Now remember that, if let's go back to the population. Let's go back to the population. So we can have three types of screening tests. Category 1 is basically a disorder which is very severe, very common in the population, and we all need to do it. So someone in the class today said कि क्या सर सबका TSH करना है? Of course, पूरे दुनिया में सबका TSH करना है. Now in India, CAH is common, G6PD is common. So all of you, for our country, at least these three tests are very important. TSH, congenital adrenal hyperplasia, and G6PD deficiency. All of these disorders are serious. If they happen in a child, he can have a crisis. So we should do all of these tests. And I'll be talking about the rest tests today. Now, category 2 of tests are only done in high risk patients. For example, someone has a consanguineous marriage, a family history. Okay. So there's a consanguineous marriage, there's a family history of a recurrent, a lethal disorder in the family. Okay, even I would say, Ashkenazi Jews. So for example, in America or Europe, cystic fibrosis could be a high risk disease. So screening for cystic fibrosis, especially in Europe and America, would be important, because 1 in every 25 Britisher and Ashkenazi Jews are carriers for cystic fibrosis. So you do these tests in high risk population. And category 3, I'm sorry here, category 3 test is basically for well-to-do families. If you have a well-to-do family, you can screen the baby for all the metabolic disorders. Okay, so if you have money, so suppose all of you have money, so you can do all the tests in your baby. That's called an extended neonatal screen. Okay, तो अगर आपके पास बहुत पैसे हैं तो do extended neonatal screen in your baby, and you're sure your baby does not have anything. Okay, so let's talk about India. We talked about TSH. And now we'll talk about CAH, congenital adrenal hyperplasia. Congenital adrenal hyperplasia. Autosomal recessive disorder, congenital adrenal hyperplasia. Remember, all of you, 90% of congenital hyperplasia, congenital adrenal hyperplasia, is a block here. Deficiency of 21 hydroxylase enzyme. So all of you please remember, 90% of CAH is deficiency of enzyme 21 hydroxylase. 21 hydroxylase. So aldosterone is not there, cortisol is not there, and there is excess of testosterone. So aldosterone is not there, cortisol is not there, and there is excess of testosterone. So NEET PG aspirants, I can bet on this question. Every NEET PG, a related question comes. Okay. So you have a child who has hyponatremia, hyperkalemia, and shock. Hyponatremia, hyperkalemia, shock. So remember, all of you, 70% of CAH presents in a salt wasting crisis. 70% of the classic CAH presents in a crisis. This baby can die. Shock, hyponatremia, hyperkalemia, and there is excess of testosterone. So what accumulates, all of you, on your screen? Can you see this? 17 hydroxyprogesterone. So what is the marker for CAH in all the babies? 17 hydroxyprogesterone. Okay, so 17 hydroxyprogesterone. Okay, so we do it by 17 hydroxyprogesterone. Okay, remember, in babies who have CAH, 17 hydroxyprogesterone is very high. It is in thousands. So this question came in NEET PG 2018, and I remember one of the students, she walked up to me after the class. She had a card in her hand, and she said, sir, she had written everything on her card. She said, sir, in my NEET PG, the question was, what are the levels of 17 hydroxyprogesterone in infants with CAH? They are in thousands. So they are usually more than 3500 nanograms per deciliter. So in NEET PG, the option was more than 600. So this was the answer in 2018. So remember, the levels are in thousands if you talk about nanogram per deciliter. So the level of 17 hydroxyprogesterone in infants is more than 3500 nanogram per deciliter, or more than 100 nanomole per liter, or more than 100 nanomole per liter. So please remember, we can, when we do a heel prick, we also look for CAH. Okay, so when we do a heel prick, we look for TSH, 17 hydroxyprogesterone, and TMS. Now, all of you, is it just about dried blood spot? Is it just about blood? No, guys, it is not just about blood. There are many other tests we can do. And the next test which I'll be talking about is cystic fibrosis. Okay, cystic fibrosis is also diagnosed by a blood test. Okay, that blood test, 2 drops of blood we do, it's called IRT, immunoreactive trypsinogen assay. So the screening test for cystic fibrosis, no, Dr. Ghosh, you're wrong. So the screening test for cystic fibrosis is immunoreactive trypsinogen assay. Immunoreactive trypsinogen assay. Now remember, cystic fibrosis is the most common cause of pancreatic insufficiency all over the world. Okay, all over the world, in babies, in children, the most common cause of pancreatic insufficiency is cystic fibrosis. So pancreas के एंजाइम नहीं है. Okay, so trypsinogen से trypsin नहीं बन रहा. Okay, so these children, this is not happening because the pancreatic enzymes are not there. So we diagnose this by an immunoassay. So we diagnose trypsinogen by an immuno or a radio assay. So इसको कहते हैं immunoreactive trypsinogen assay. Okay, it is 80% sensitive. So for a screening, you need a sensitive tool. So it's 80% sensitive to diagnose cystic fibrosis. Okay, the second test you can do is DNA analysis. So all of you, all over the world, most commonly they would do IRT followed by a mutation. Okay, so every baby who has immunoreactive trypsinogen test positive, we follow it up by a DNA analysis and a sweat chloride. Okay, तो नॉर्मल बच्चों में स्वेट क्लोराइड नहीं करते फॉर स्क्रीनिंग डॉक्टर घोष वी डू IRT. Okay, so let's take you to, so is it all about blood tests? No, there are many other tests which we do in a newborn even without a blood test. You forgot about hearing. So of course we do hearing assessment in every baby of the world. Every baby in the world, when we discharge the baby, we do hearing assessment. I will not take you to ENT, but I'll just tell you that we have two tests for hearing assessment in a newborn. In a newborn, we have two tests for hearing assessment. One is called auto-acoustic emission. OAE, auto-acoustic emission. So on your right, this photograph shows auto-acoustic emission, where what we do is basically we insert, this device, okay, in the baby's ears, okay, and we give him tones, and then based on his hearing, we assess the hearing deficit. And on your left, we have a test called AABR. What is AABR? It is automated auditory brainstem response. Automated, you're right, Dr. Vedya, automated auditory brainstem response. Okay, and you can see here that we have kept an electrode here on his forehead and on his mastoid. Okay, so sometimes they also keep an electrode at the nape of the neck also. So you have an electrode at the, at the forehead and at the mastoid. So which test is good? So ideally, all of you, we need to do one first. So basically we have a two-step technique. So all the guidelines, whether it's American Academy of Pediatrics or the AIIMS NICU guidelines, they say ideally you should do two-step technique. इसका क्या मतलब है two step? You do OAE test or AABR. Okay, you do OEE or AABR. Now, if any of them, all of you, if any of them is abnormal, suppose एक बच्चा fail कर गया OAE, then you do the other test. Okay, so it has been seen if you do both of these tests, they have excellent sensitivity and specificity to diagnose deafness in children. Okay, so Dr. Ghosh, so for screening you can do any of them, and if one is you fail in one, you do the other one. And if a patient fails both, this child needs formal hearing assessment. At almost 1 month of life, he needs a formal hearing assessment. So all of you, it is not just about blood test. Hearing assessment is also important. And now the last and the very important point of the day, which is very important for the NEET PG aspirants. Don't sleep, NEET PG aspirants, very important. What is this on your screen? What is this photograph showing on your screen? Pulse oximetry. So all the babies in the world, when they are born, guys, we do a pulse oximetry to diagnose heart disorders. So we do a pulse oximetry to diagnose heart disorders. Okay, and where do we keep a pulse oximeter? Where do we keep a pulse oximeter? Dr. Anvesha, ROP is only for preterms. हम कह रहे हैं These disorders are, this screening test is for everyone, every baby in the world, term या preterm, सबका करना है saturation. You have to do pulse oximetry in all, and we do pulse oximetry on the right upper limb and any of the lower limbs. So हमारे पास दो pulse oximeters होते हैं, okay, and we look at the difference between the right upper limb and any of the lower limbs. So what is the rationale of pulse oximeter, guys? The rationale of pulse oximeter is, all of you have heard about fetal circulation, that we have a ductus arteriosus here which connects the pulmonary artery to the aorta. Okay, so we have a fetal circulation in which we have ductus arteriosus which joins the pulmonary artery to the aorta. So the rationale is, guys, that ductus arteriosus closes physiologically within the first 10 to 15 hours of life. It closes physiologically within the first 10 to 15 hours of life, and anatomically within the first 10 to 21 days. Okay, so physiologically within the first 10 to 15 hours and anatomically within the first 10 to 21 days of life. Okay, so there are a lot of disorders which are dependent on the ductus arteriosus. As soon as the ductus closes, these children come to our hospital. So as soon as the ductus arteriosus closes, ये बच्चे आ गए हमारे hospital में. Okay, so suppose all of you, I show you a disorder on the right side. I'll just not take a lot of time, just few minutes more. So for example, if I show you a disorder on the right side, right-sided disorder, for example, tricuspid atresia, okay, then what else? A severe pulmonary atresia. If you have a severe right-sided disorder, for example, tricuspid atresia or pulmonary atresia, जब तक ductus खुला है, everything is fine. As soon as the ductus closes, the blood does not go to lungs. Can you see? Now blood cannot go to the lungs. So these children present to you with central cyanosis. All of you, these children are dependent on the ductus arteriosus for the pulmonary blood. So all of you, please write, I'll just tell you 3 points. Just 3 points लिख लो and we'll close the class. Right-sided disorders, tricuspid atresia, pulmonary atresia. Okay, they are dependent on the ductus arteriosus for the pulmonary blood. जैसी बच्चा पैदा हुआ, lung में blood नहीं जा रहा, no blood is going to the lungs as soon as he is born. So he needs a ductus arteriosus to give the blood to the lungs. So now as soon as the ductus arteriosus, जब तक खुला है, from ductus arteriosus the blood will go to the lungs. Okay, so please write. I've already told you in your classes, in your regular classes. So right-sided lesions are dependent on the ductus arteriosus for the pulmonary blood. As soon as the ductus closes, they come in central cyanosis. Okay, so जैसी ductus बंद हुआ, बच्चा cyanosis हो गया. So we need to give him prostaglandin to open the ductus. Let's talk about left-sided disorders, guys. The left-sided disorder, for example, hypoplastic left ventricle. Hypoplastic left ventricle. Critical aortic stenosis. Hypoplastic left ventricle, critical aortic stenosis, and coarctation of aorta, a preductal coarctation. A preductal coarctation. Hypoplastic left ventricle, critical aortic stenosis, and a coarctation of aorta, preductal. Now all of you, as soon as the baby is born, there is no blood to the systemics. Systemics को blood नहीं मिल रहा. So the systemics blood is given by the ductus arteriosus. So please remember all of you, number 2, systemic blood flow dependence, the left side problems, systemic blood flow dependence, they present with shock. Within the first week of life, they will come with shock. Okay, left ventricle तो देखो, left ventricle छोटा सा है. There is a severe coarctation before the ductus. So as soon as the ductus closes, they go into shock. So you need to put them on prostaglandin. So you need to diagnose it early. Okay. And the third disorder is TGA. What do I mean by TGA? That aorta is arising from the right, pulmonary artery is arising from the left. TGA का मतलब है transposition of great arteries. Transposition of great arteries. So impure blood comes to the right side, goes back to the systemics. Impure blood goes back to the systemics. Impure blood goes back to the systemics. The pure blood comes to the left side in TGA, goes back to the lungs. So the pure blood goes back to the lungs in TGA. So TGA has two circuits, a systemic unoxygenated and a pulmonary oxygenated. जैसे ही बच्चा पैदा हुआ, he goes into central cyanosis. जैसे ही बच्चा पैदा हुआ, he goes into central cyanosis. TGA has two parallel circuits. Okay, so all of you, in fact, TGA is the most common cause of cyanosis in a newborn. TGA is the most common cyanotic heart disease in a newborn. In my hospital where I work, we see TGA every day. One TGA every day comes to my hospital. He needs mixing. All of you, if I open his ductus arteriosus, it gives him mixing. So prostaglandins give him mixing. Okay, so prostaglandin give him mixing. Okay, so please remember that prostaglandins give him mixing in case of TGA. And remember all of you, TGA is the most common cause of cyanosis, cyanotic heart disease in a newborn. So all of you, now एक और non-invasive test, pulse oximetry. Okay, so I'll just tell you a non-invasive test, pulse oximetry. So if you have saturation less than 95%, okay, in any limb, or there is a difference more than 3%, okay, there's a difference more than 3% between the right upper limb and lower limbs, this child needs evaluation. Okay, मैं फिर से बोलूँगा, last sentence of the day almost. If there's a saturation less than 95% in any limb, or there is a difference more than 3%, okay, difference of saturation more than 3% between right upper limb and any of the lower limb, you need to evaluate this child. And why are we talking about right upper limb, all of you? Because right upper limb is preductal. This question came in NEET PG 2019. Right upper limb is preductal. So it is a convention. Right upper limb is preductal, lower limbs are postductal. So we are looking at the difference between the upper limbs and the lower limbs, especially for TGA. So this child should be evaluated because he may need prostaglandin infusion. So that was all about today. So the take home points for all of you is that screening tests are very important. You need to remember about TSH, tandem mass spect for metabolic disorders, okay, and don't forget 17 hydroxyprogesterone for CAH, hearing assessment in newborns, and a pulse oximetry. We do this in every baby, okay. अगर एक बच्चा अच्छे हॉस्पिटल में पैदा होता है, we do all of these tests, okay. Otherwise you can leave it to God. If he has the disease, he will present with that disease and then we diagnose it. So you decide. We diagnose those disorders early. This child already has a disease, but we are trying to diagnose it early to prevent the complications. या फिर जब कोरोना हो जाएगा तो we diagnose corona. So either you wear a mask or diagnose it when it's there. Okay, so that was all about my class. This is just a demo for the DAMS Ultimate Life course which we are coming up. So all of you who are not from DAMS, we are very excited about these classes because these will be live, and we will also have very excellent sessions. We will have, I'll show you live hands-on videos also in these sessions. And if you want to join this, there's a referral code by my name, Dr. Simet 235. You can join it and have a 10% discount on that. And so yeah, we need to diagnose these disorders early. I'll just take the questions if you have questions. Yeah, Dr. Anu, please remember the right upper limb saturations. I have told you in your neonatal classes. So look at the targets. Yes, almost 85 to 95% of saturation comes after around 10 minutes of life. Okay. So I can tell you guys, that you will definitely get a question like this in your exam. Okay. So SpO2 assessment should be done, all of you, at birth, but there are some targets. Please look at those targets, Dr. Aswathi. So all of you, this is very important. Neonatal resuscitation, I've already told you in your classes, in your regular classes. We'll only take academic questions here. Okay. And Happy New Year to all of you. And I hope this year we go to our hospitals without masks and we are able to have coffee. We've been deprived of coffee in our hospitals. Caffeine is very important for all of us. And I hope to see all of you on the other side very soon this year. Thank you.